Hi everyone. Today's topic is health education. Learning outcomes. Explain the basis of oral health education, then describe the principles of health education, explain primary, secondary, and tertiary prevention. Definition. Health education is a process that informs, motivates, and helps people to adapt and maintain healthy practices and lifestyles, advocates environmental changes as needed to facilitate this goal, and conducts professional training and research to the same end. The goal of health education is to influence behavioral change. Yet changing habits is extremely difficult for most of us. Healthcare providers ask patients to make enormous changes in their lives in order to prevent disease and promote health. For example, we ask children to brush after they consume chocolates in order to decrease their increased risk of dental caries. In addition, the children must take care of oral hygiene. Self management of oral hygiene to avoid dental caries is very complex. Yet, we ask ordinary people to take all these tasks and at the same time carry on their normal life of school and social relationship. Theories that explain human behavioral change serve as a guidelines for teaching. Theories are generalized set of rules that can help us find answers for patient learning and motivation and help predict the consequences of specific health education intervention. The more you know about the educational theories, the more tools you will have for building strong, effective patient education interventions. The Declaration of the Alma Ata in 1978 states that a process aimed at encouraging people to want to be healthy, to know how to stay healthy, to do what they can individually and collectively to maintain health, and seek help when needed. The modern concept of health education emphasizes on health, behavior, and related actions of people. Aims and objectives. Almata Declaration, adopted in 1978, provide a useful basis for formulating the aims and objectives of health education, which may be stated as below: to encourage people to adopt and sustain health promoting lifestyles and practices, to promote the proper use of health services available to them, to arouse interest, provide new knowledge, improve skills, and change attitudes in making rational decisions to solve their own problems, to stimulate individual and community self reliance and participation to achieve health development through a individual and community involvement at every step from identifying problem to solving them. Role of the healthcare providers. The role of healthcare providers in this regard comprise to provide opportunities for people to learn how to identify and analyze health and health related problems and how to set their own targets and priorities. Make health and health related information easily accessible to the community. Indicate to the people alternative solution for solving the health and health related problem they have identified. People must have access to proven preventive measures. Approaches to health education. First is a regulatory approach. I think we will be knowing, like, we have to wear helmet if you are riding a bike, or you have to wear seat belt if you are driving a car. What is that? Government is imposing on you to wear helmet or wear seat belt so that there should be a less impact if you met with any accident or less injury onto you. So that is a regulatory approach that compulsory we have to follow. So regulations are made by the government. So that approach is called regulatory approach. So regulatory approach seeks change in health behavior and improvement in the health through a variety of external control or laws placed on people. The second is service approach. It aimed at providing all the health services needed by the people at their doorsteps on the assumption that people would use them to improve their own health. For example, in our primary health center, if you register for one ringgit, you will be getting treatment for small diseases. So that is service approach. Health education approach. It is general belief in Western democracies that people will be better off if they have autonomy over their own lives, including health affairs on which an informed person should be able to make decisions to protect his own health. These are the higher goals of health education. Primary healthcare approach. This is a radically new approach starting from the people with their full participation and active involvement in the planning and delivery of health services based on the principles of primary healthcare, community involvement, and intersector coordination. The underlying objective is to help individuals to become self reliant in matters of health. What is the difference between health education and propaganda? First difference is knowledge and skills are actively acquired in case of health education. But in case of propaganda, knowledge installed in the minds of the people. In case of health education, makes people think for themselves. But in the case of propaganda, prevents thinking by ready-made slogans. In case of health education, disciplines primitive desires, but in propaganda arouses primitive desires. In health education, appeals to reasons, propaganda appeal to emotions. In health education, develops individuality, personality, and self-expression. Propaganda develops a standard pattern of attitude and behavior. Knowledge acquired through a self-reliant activity in case of health education, knowledge is spoon-feeded in case of propaganda. In health education, process is behavioral centered. In propaganda, process is information centered. In health education, develops reflective behavior. In propaganda, develops reflexive behavior. Reflective and reflexive. See, for example, if what is the difference between reflective and reflexive means? For example, if you are going in high speed, suddenly one bicycle fellow come in between to you. That reflex of putting brake is reflex. If you are viewing something in the mirror, that is reflect. You have studied and you have scored good marks. So that scoring good marks is the reflection of whatever you studied. That means if you have gained the knowledge and how you changed your behavior, that is reflection. That's what our health education helps. Models of health education. Medical model. The assumption was that people would act on the information supplied by the health professionals to improve their health. In this model, have social, cultural, psychological factors were thought to be of little or no importance. The medical model did not bridge the gap between knowledge and behavior. See, medical model means there is a disease, treat with the tablet or injection. But some problems like depression, we can't treat with medication always. You have to check the what is the main cause. For example, uh, some students, parents, they are unhappy that their kids are not studying well. Maybe because their adjacent or neighbor or their senior officers, their son or kids are studying well. So that might be the social pressure for them. See, his son is studying well, my son is not studying. So that is social factor. So medical model is not helping in solving the social and cultural and psychological factors. So this is not that successful model. Coming to motivation model, in this there will be first is to create the awareness. In health education, we must first create awareness of health needs and problems through a program of public information. First is awareness, then comes your motivation, includes the stages of interest, evaluation, and decision making. The individual events interest in the subject, he may seek more detailed information about the usefulness and limitations or applicability of new idea or practices. For example, if you want to read this topic, I have to create interest in you. How I can create? I should tell what is the importance of health education and how it should be. So adoption. The new idea or acquired behavior becomes part of his own existing value. This is called internalization. For example, you know how to brush. So even though when you wake up early morning, even though you are in slight sleepy, you will be doing proper brushing. If you know very well, that is called internalization. So subconsciously or consciously, you will be doing a proper method. Social intervention model. The motivation model ignored the fact that in number of situations, it is not that individual who needs to be changed, but the social environment which shapes the behavior of individual and the community. It is often found that people will not readily accept and try something new or novel until it has been legitimated or approved by the group to which they belong. Coming to contents of health education. First is human biology, second is nutrition, hygiene, family health, disease prevention and control, mental health, prevention of accidents, use of health services. Coming to principles of health education. This is most important because it will come for 10 marks question for your exam. Credibility. This is the first principle. It is a degree to which the message to be communicated is perceived as trustworthy by the receiver. Good health education is based on the facts. That means it must be consistent and compatible with the scientific knowledge and also with the local culture, educational system, and social goals. So, whatever you give as an health education material, it should be credible. That means it should be trustworthy. The second is interest. It is a physiological principle that people are unlikely to listen to those things which are not to their interest. If a health program is based on felt needs, people will gladly participate in the program and only then it will be people's program. Participation. Health education should aim at encouraging people to work actively with the health workers and others in identifying their own health problem and also in developing solution and plans to work them out. So, according to this, participation is very important. Then motivation. In every person, there is a fundamental desire to learn. Awakening this desire is called motivation. There are primary motives and secondary motives. In primary motives like hunger, survival, are driving forces to initiating people into action. This motivates our inborn desires. That's why it is primary motives. There are some secondary motives are based on desires created by outside forces or incentives like love, rivalry. So you have to stimulate them to or motivate them to adopt the new styles or lifestyles or healthy lifestyles. Comprehension. In health education, you must know the level of understanding, education, and literacy of people to whom the teaching is directed. One barrier to communication is using words which can't be understood by the listener or the patient. See, whatever you should tell in health education, it should be of normal word, day to day word where common man is using. If you are telling scientific word, the common man won't understand. Reinforcement. Few people can learn all that is new in a single period, but some people will be, it will take some 3 or 4 times to read or write or to listen, then only they will be able to understand. They are called slow learners. Whether it is fast learner or slow learner, repetition is always good. Repetition at interval is necessary. That's why it is reinforcement. Whatever you teach, whatever you read, you have to reinforce. Learning by doing. Learning is an action process, not a memorizing. One in the narrow sense, the Chinese proverb, if I hear, I forget. If I see, I remember. If I do, I know. Illustrate the importance of learning by doing. Noun to unknown. In health education work, we must proceed from the concrete to the abstract, from the particular to the general, from the simple to the more complicated, from the easy to more difficult, and from the known to unknown. These are the rules in teaching health education. We start where the people are and with what they understand, and then proceed to new knowledge. Setting an example. The health educator should set a good example in the things he is teaching. If he is explaining the hazards of smoking, he will not be very successful if he himself smokes. That means whatever you tell, before that you have to follow that. Then only you can tell to the people. Good human relations. Sharing of information, ideas, and feelings happen most easily between people who have good relationship. Building a good relationship with people goes hand in hand with developing communication skills. Feedback is one of the key concepts of system approach. The health educator can modify the elements of system like message channels in the light of feedback from his audience. For effective communication, feedback is of paramount importance. Then leaders. Psychologists have shown and established that we learn best from the people whom we respect and regard. In the work of health education, we try to penetrate the community through the local leaders, the village headman, the school teacher, or political worker. Practice of health education. Educational material should be designed to focus attention to provide new knowledge, to facilitate interpersonal and group discussion, and to reinforce or clarify prior knowledge and behavior. Audiovisual aids like auditory aids like radio, tape recorder, microphones, amplifiers. Visual aids not required projections like chalkboard, leaflet, poster, charts, flannel graph. Requiring projections like slides, film strips, combined audiovisual aids or television slide tape combination. Coming to the health communication, there are three approaches in health communication. First is individual approach, second is group approach, the third is mass approach. Under the individual approach, personal contact, home visits, personal letters. These are comes under individual approach. In the group approach, there are lectures, demonstration, and discussions. Discussion includes group discussion, panel discussion, symposium, workshop, etc. The mass approach, television, radio. In the mass approach, you can include your social media. Individual approach. It may be given in personal interviews, in the consultation room of the doctor, or in the health center, or in the homes of the people. The individual comes to the doctor or health center because of illness. Opportunity is taken in educating him on matters of interest, diet, causation, nature of illness, and its prevention, personalizing environmental hygiene. The biggest advantage of individual health teaching is that we can discuss, argue, and persuade the individual to change his behavior. It provides opportunities to ask questions in terms of specific interests. The limitation of individual health teaching is that the numbers we reach are small and the health education is given only to those who come into the contact. Group approach. Our society contains groups of many kinds of school children, mothers, industrial workers, patients, etc. Group teaching is an effective way of educating the community. The choice of subject is group healthy teaching is very important. It must relate directly to interests of group. For example, we should not broach the subject of tuberculosis control to mother who has come for delivery. We should talk to her about the childbirth and baby care. Chalk and talk. A lecture may be defined as carefully prepared oral presentation of facts, organized thought and ideas by qualified person. The chalk lends the visual component. The chalk and talk communication has still a very important place in small group education. Its effectiveness depends to a large extent on the speaker's ability to write legibly and to draw with chalk on the blackboard. The talk should be based on a topic of current interest or health needs of the group. The group should not be more than 30 and talk should not be exceed 15 to 20 minutes. If the talk is too long, people may become bored and restless. The lecture method can be made more effective by combining with the suitable audiovisual aids, such as flip charts. They consist of series of charts about 25 by 30 centimeter or more, each with an illustration pertaining to the talk to be given. They are meant to be shown one after another. Each chart is flashed or displayed before a group as the talk is being given. The message on the charts must be brief and to the point. These charts are primarily designed to hold attention of the group and help the lecture to proceed. Flannel graph. A piece of rough flannel fixed over the wooden board provides an excellent background for displaying cutout pictures, groups, drawings, and other illustration. Flannel graph offers the advantage and pre-arranged sequence of pictures displayed one after another helps maintaining continuity and adds much to the presentation. Exhibition. Objects, models, specimens convey a specific message to the viewer. They are essentially mass media of communication which can also be used in group teaching. Films and charts, these are mass media of communication. If used with a discrimination, they can be of value in educating small groups. Lectures can be faulted on the number of grounds. Their disadvantage include the following: students are involved to minimum extent, learning is passive, do not stimulate thinking or problem solving capacity. The comprehension of lectures varies with the student and the health behavior of the listeners is not necessarily affected. Demonstration. Demonstration is carefully prepared presentation to show how to perform a skill or procedure. Demonstration is like dramatizes by arousing interest, persuades the onlookers to adopt recommended practices, upholds the principles of seeing is believing, learning by doing, can bring desirable change in the behavior pertaining to the use of new practice. Demonstration as a means of communication has been found to be have high educational value in programs like environmental sanitation, mother and child health, and control of disease. The clinical teaching in hospital is based on the demonstration. This method has an high motivation value. Group discussion. A group is an aggregation of people interacting in face-to-face situation. This contrasts sharply to the group of students in classroom situation. It permits the individual to learn by freely exchanging their knowledge, ideas, and opinions. For effective group discussion, the group should be comprised not less than 6 and not more than 12 members. The participants are all seated in a circle so that each is fully visible to all others. There should be a group leader who initiates the subject, helps the discussion in the proper manner, prevents side conversation when it is deviating, then encourages everyone to participate and sums up with the discussion in the end. Limitations. Group discussion is not without limitation. Those who are shy may not take part in the discussion. Some may dominate in the discussion. Thus, there may be an unequal participation of members in a group discussion. Unless properly guided, some members may deviate from the subject and make the discussion irrelevant or unprofitable. Coming to panel discussion, a panel comprises a chairman or a moderator and from 4 to 8 speakers. The chairman opens the meeting, welcomes the group, and introduces the panel speakers. He introduces the topic briefly and invites the panel speakers to present their point of views. There is no specific agenda, no order of speaking, and no set speeches. The success of panel depends upon the chairman. He has to keep the discussion going and develop the train of thought. After the main aspects of the subjects are explored by the panel speakers, the audience is invited to take part. Panel discussion can be an extremely effective method of education provided it is properly planned and guided. Symposium. A symposium is a series of speeches on selected subject. Each person or expert presents an aspect of the subject briefly. There is no discussion among the symposium members like in panel discussion. In the end, the audience may raise the questions. The chairman makes a comprehensive summary at the end of entire session. Workshop. The workshop is the name given to novel experiment in education. It consists of series of meetings, usually 4 or more, with emphasis on individual work within the group with the help of consultants and resource personnel. The workshop provides each participant opportunities to improve his effectiveness as professional worker. Conferences and seminars. This category contains a large component of commercialized continuing education. They range from one's half day to 1 week in a length and may cover a single topic in depth or be broadly comprehensive. They usually use a variety of formats to aid the learning process from self instruction to multimedia. Role playing. Role playing or social drama is based on the assumption that many values in situation can't be expressed in words, and the communication can be more effective if the situation is dramatized by the group. It is particularly useful educational device for school children. Role playing is followed by discussion of the problem. Mass approach, that is education of the general public. Mass media are a one-way communication. They are useful in transmitting messages to people even in remotest place. The number of people who are reached usually count in millions. Their effectiveness can be high returns for the time and money involved. Public health methodologies should be culturally appropriate. They should be carefully thought out before use. Lists of mass media, television, radio, internet, newspaper, printed material, direct mailing, posters, billboards, health museums, folk media. Prevention. The goals of medicine are to promote the health, to preserve the health, to restore the health when it is impaired, and to minimize suffering and distress. These goals are embodied in the word prevention. Successful prevention depends on a knowledge of causation, dynamics of transmission, identification of risk factors, and risk groups, availability of prophylactic or early detection and treatment measures, on organization for applying this measure to appropriate person or groups, and continuous evaluation of development of procedures applied. Coming to levels of prevention, there are four prevention levels like primordial prevention, primary prevention, secondary prevention, and tertiary prevention. Coming to primordial prevention, it's a new concept is receiving special attention in the prevention of chronic diseases. This is primary prevention in its purest sense, that is, prevention of emergence or development of risk factors in countries or population groups in which they have not yet appeared. In primordial prevention, efforts are directed towards discouraging children from adopting harmful lifestyle. The main intervention in primordial prevention is through individual and mass education. Primary prevention. It is the action taken prior to the onset of disease which removes the possibility that a disease will ever occur. It includes the concept of positive health, a concept that encourages achievement and maintenance of an acceptable level of health that will enable every individual to lead a socially and economically productive life. Coming to modes of intervention in primary prevention, there are two modes of intervention, that is health promotion and specific protection. Coming to secondary prevention can be defined as action which halts the progress of a disease at its incipient stage and prevents complications. Modes of intervention includes early diagnosis, which includes screening tests, case finding programs, and early treatment, that before irreversible pathological changes takes place. This is imperfect tool in the control of transmission of disease. It is often more expensive and less effective than primary prevention. In the long run, human health, happiness, and useful longevity will be achieved at far less expense with less suffering through a primary prevention than through secondary prevention. So, primary prevention is better than secondary prevention. For example, proper toothbrushing, that's primary prevention. Already decay is there and you want to go for restoration or you want to check, that comes in secondary prevention. If already decay is there and it's having pain, that's tertiary prevention. When the disease process has advanced beyond its early stages, it is still possible to accomplish prevention by what might be called tertiary prevention. The modes of intervention are disability limitation and rehabilitation. In disability limitation, all measures available to reduce or limit impairment and disabilities, minimize suffering caused by existing departure from good health, and promote the patient's adjustment to irremen- irremediable conditions. For example, after tooth decay, it went for root canal treatment. So, when during pain, person is unable to eat or chew, so that is disability limitation. So we have to treat that. So we have done the RCT and we have given crown on the tooth, RCT treated tooth. That is rehabilitation. Or you have extracted the tooth and you have given prosthesis. That is rehabilitation. So you have to link what is the prevention. First motto is there should be no disease. So what we have to do? Primary prevention. Proper toothbrushing and proper nutrition. Then secondary prevention. Self-examination of dental caries. Whether white patch is there or any dark spot on the tooth surface. That is secondary. That is screening. Tertiary, already decay is there. Either you have to go for restoration or if it is too deep, then we have to go for root canal. Sometimes both the treatments can't be done because it's grossly destructed. Then it will go for extraction. Once it go for extraction, we have to go for prosthesis. That is your tertiary prevention. So depending on the stage of the disease, you are going to give the prevention. This is just for example for dental caries, but it applies for all the diseases. So we'll discuss other things in part 2. Thank you.